Okay guys, welcome back. This time the topic that we shall be talking about is related to parathormone. We shall be talking about parathyroid glands, and the objective would be to understand aspects related to calcium metabolism. As far as PTH is concerned, one of the very important functions of PTH is that it is responsible for bone reabsorption. By causing this activity, PTH will attempt to increase calcium in the body. The second action is that it will act on the proximal converted tubule of the kidney, and it causes a phosphate wasting. This will form the essence of majority of MCQs. You need to remember that PTH hormone affects the proximal converted tubule of the kidney, and it is responsible for phosphate wasting. So the values of phosphate in the body of the patient will begin to fall. This is also responsible for increasing the bone turnover. And if you increase the bone turnover in the body, then it will result in upgrade of serum alkaline phosphatase, which is itself an MCQ that what is the best marker of bone turnover? SAP. There are two types of cells in the bones. One is known as osteoclasts, which are having a bone destroying action, and second is osteoblasts, which are having a bone forming action. Now when it comes to osteoclasts, that is bone destruction, or osteoblast, which is bone forming, remember the fact that the one that is producing SAP is osteoblast, B for Bombay. It is not osteoclast, it is osteoblast. How that happens is that during bone reabsorption, osteoclastic activity is upgraded. Now clast Calcutta activity is upgraded, so there is a secondary increase in osteoblastic activity, and that results in increase in the SAP values of the patient. So we will have an increase of calcium, loss of phosphate, and we will have an increase of SAP in the patient. Serum alkaline phosphatase is always increased in conditions of increased bone turnover, whether it be rickets in children, whether it would be osteomalacia in adults, and even in hyperparathyroidism, there is an increase in bone turnover, so SAP values would be upgraded. They've asked in what condition would the serum alkaline phosphatase values be downgraded, lesser. Serum alkaline phosphatase becomes lesser, not in hypoparathyroidism. Do not fall for that trap. The examiner will emphasize hypoparathyroidism in the options, but it is not to be marked as hypoparathyroidism. This is to be answered as hypophosphatasia. So for decrease in serum alkaline phosphatase in a patient, remember the answer is to be given as hypophosphatasia and not as hypoparathyroidism. Disproportionate rise of SAP is seen in Paget's disease. If the question is asked as what happens to serum alkaline phosphatase in patients who are having hypoparathyroidism, your answer would be SAP is normal in patients of hypoparathyroidism. Serum alkaline phosphatase values are also normal in multiple myeloma. Serum alkaline phosphatase values are also normal in patients who are having osteoporosis. But these are four basic MCQs on the topic of serum alkaline phosphatase, which I would like to say is a must know for you for this particular topic. SAP values are elevated in rickets, osteomalacia, and hyperparathyroidism. They are lesser in hypophosphatasia, disproportionately rising in Paget's disease, and normal in hypoparathyroidism-minded multiple myeloma and osteoporosis. Now, based on this discussion, let us now look at what's going to actually happen if the PTH values in the patient would be upgraded, and the topic that we are discussing now is known as primary hyperparathyroidism. In primary hyperparathyroidism, there would be a tumor in any one of the parathyroid glands. So hypothetically, I have shown here a tumor in one of the parathyroid glands. Once the parathyroid gland will become relatively bigger, then what's going to happen next is that the PTH values will cause more bone reabsorption, and the calcium in the blood of the patient will begin to increase. If calcium will begin to increase, we very well know that normal calcium in the body is between 9 to 11 mg/cent. So in this case, the values would obviously be spiking. In primary hyperparathyroidism, because calcium is more, this calcium will be deposited in the tissues of the kidney. There would be nephrolithiasis. Due to increase in urinary calcium, there will be nephrolithiasis, and subsequently the crystals will crystallize to cause stone formation, so there would be nephrocalcinosis. So all patients of hyperparathyroidism will develop features of hypercalcemia, and nephrocalcinosis will develop. Patient will describe flank pain. The flank pain will go to the umbilicus. The features will mostly be given of renal colic. Flank pain going towards the umbilicus would be the presentation. This might be associated with multiple hospitalizations because of recurrent vomiting episodes. You see, renal colic is always associated with renogastric reflex. So there will be a pylorospasm, and pylorospasm would contribute to development of multiple episodes of vomiting in the patient. So nephrocalcinosis will present as a renal colic, and there would be multiple such episodes, and patient might require interventions also. Like if the size of the stone is 1.5 centimeter, then he might be requiring a lithotripsy, and if the size of the stone is 3.5 centimeter, then he might be requiring percutaneous nephrolithotomy, and he might say that I have gone more than one such procedures in last year and this particular year. This is because these are people who are having tendency to form stones. The second complaint of this patient due to hypercalcemia will be spasm of the sphincters of the gut. More calcium will cause spasm of the sphincters of the gut, which will result in severe constipation. This constipation will be refractory to even laxatives, because you see, if somebody is having hard stool due to constipation, if somebody is having constipation due to hard stool, you can use a laxative in a patient. But in this case, even if you are using a laxative, it will not be of too much of use for the patient. Following kidney stones and constipation aspect, which will explain the abdominal pain as a predominant presentation of the patient. The higher values of calcium can also result in development or deposition of calcium in the skin of the patient. So these patients could be having lumps or bumps in the skin which are gonna hurt. That is calcinosis cutis. The calcium is getting deposited in the skin of the patient. The calcium will also cause hardening of blood vessels. Due to hardening of the blood vessels of the patient, there can be a development of pseudo-hypertension. I'm calling it a pseudo-hypertension because actually it is not that there is a genuine increase in peripheral resistance in the body. It is just the fact that his BP values are coming to be higher because of the hardening of the blood vessels. As the values of calcium increase further in the body of the patient, these patients will also be having development of psychosis. So due to this psychosis, they will always be having complaints of moaning and groaning. So hyperparathyroidism in MCQ is described as a patient with abdominal pain, moaning and groaning. That's because of the psychosis component that comes in. As the values of calcium will start going beyond 12 milligram percent, going up to 13 milligram percent and higher, then more problems are gonna creep up for the patient. With higher values, you will also be having calcification of the basal ganglia. Therefore, this patient with calcification of the basal ganglia will then start developing features of secondary Parkinsonism, which means the fact that patient will be having symptoms in the form of bradykinesia, or the question might mention regarding rigidity. Neurological symptoms will also develop in these patients because calcium will get deposited in the basal ganglia of the patient, resulting in secondary Parkinsonism. So higher is the value of this patient, more will be the problems that will be developing in these patients. As the values of calcium will start going higher, that is beyond 14 milligram percent going towards 15, that is when we start having a high incidence of systolic arrest. The reason why we're discussing this topic is mainly to explain to you that once the calcium values will start touching towards 14, therefore there would be a higher incidence of systolic arrest in the patient, which might cause expiry of the patient. Symptoms of hypercalcemia would be in the form of abdominal pain, moaning and groaning due to psychotic component, and there would be neurological symptoms in the form of secondary Parkinsonism in the patient. So in the workup of this patient, you will have to check for the values of serum calcium, phosphate, and serum alkaline phosphatase of this patient. And you will notice the fact that in this patient, serum calcium will be more, phosphate would be less, and SAP would be disproportionately elevated in the patient. So in patients who are having hyperparathyroidism, there would be more calcium, phosphate is lost in the urine, SAP would be increased. You look at this report and you know it is PTH which is responsible for it, because PTH is always responsible for calcium and phosphate going the other way around. So you will get a serum PTH assay done in the patient, and this will always be found to be elevated. Maybe you get a doubling, tripling value because PTH is being produced by a tumor. So I now need to go for a tumor localization. I need to identify that there is a parathyroid adenoma in the patient. This was asked in last year AIMS, that what scan is done for parathyroid adenoma. The answer would be SYSTA-MIB scan. You will be doing a technetium-99 scan in the patient, and you will be able to locate the tumor, which is the villain behind the development of all these problems. The best test for tumor localization in pheochromocytoma would be MRI followed by a scan, that is MIBG scan, but here the answer would be given a system EB scan, that is a technetium 99 scan. Now it's the time for treatment. The treatment of choice for this guy is surgery, but no surgeon would be willing to touch a patient with elevated calcium at risk for systolic arrest. So first we will have to do medical management of the patient. We will have to do medical stabilization of the hypercalcemia component of the patient. In the medical stabilization of the hypercalcemia component which is present in this patient, you will first have to start the patient on a normal saline drip. This will cause a dilutional effect, and the dilution effect will result in the values of calcium of the patient to touch the lower limits of 13 or lesser, which will reduce the chances of development of systolic arrest. The second thing to be done in this patient is to initiate furosemide in the form of a drip for the patient, that is added to the bottle normal saline, because furosemide causes calcium loss. Furosemide causes calcium loss in the urine, and I'm pretty satisfied with this because if I kick out the calcium from the body, which is excess, then the job is done. We will now be starting this patient on drug of choice. The drug of choice for management of these patients of hypercalcemia is bisphosphonates. So the bisphosphonate that will be started in this patient will be ibandronate. We can also start the patient on calcitonin nasal spray. Calcitonin nasal spray is an antagonist of PTH. So it will send calcium in the bone, and if you send calcium in the bone of the patient, then serum calcium of the patient will definitely stabilize. So this is for medical stabilization, after which you will achieve a pre-anesthetic checkup and a fitness certificate. And once you get a pre-anesthetic checkup and a fitness certificate in the patient, then it's time for treatment of the resection of the parathyroid adenoma, which is the treatment of choice for management of patients of primary hyperparathyroidism. Remember the fact that the best treatment or treatment of choice is surgery, but primary treatment for the patient should be always answered as hydration of the patient, followed by furosemide drip, followed by ibandronate for management of the patient. This is discussion for hyperparathyroidism. Okay guys, the next topic that we shall be studying is by the name of hypoparathyroidism. The values of PTH here would be down and reduced, so we need to see what is the reason behind it. One of the leading reasons for development of hypoparathyroidism in a patient is autoimmunity. Following autoimmunity, the second most important reason of why you would be having this kind of a situation could be thyroid surgery. You see, during thyroid surgery, like for example, if a total thyroidectomy is being done in the patient, then there's a possibility that there might be an inadvertent parathyroid resection in the patient, and this inadvertent parathyroid resection will result in development of a hypoparathyroidism in a patient. The third cause for this could be Dye-George syndrome. This disease is related to chromosome number 22, and the manifestations in the patient would be that in Dye-George syndrome, the thymus gland of the patient and the parathyroid gland of the patient both are exhibiting a hypoplasia. So because there is a hypoplasia of the thymus gland of the patient, the cell-mediated immunity of the patient is on the lower side, which will explain the recurrent infections like pneumonia seen in the patient. And because there is a parathyroid gland hypoplasia in a patient, the value of PTH in the body of the patient will be reduced, and the low value of PTH in the body would mean that the values of calcium in the body of this patient will also become less. So there are two reasons why Dye-George syndrome is asked. One is for the immunity part and second for deficiency of calcium. This deficiency of calcium will cause rickets-like illness in the patient. I repeat again, this is not nutritional rickets, it is rickets-like illness in the patient. So I'm highlighting the fact that this person will have features like rickets, like wide open anterior fontanelle or delayed dentition, etc. could be features that are given in Dye-George syndrome. A combination of the two is the syndrome itself, which is chromosome 22 defect. Now once we know the causes, we are now understanding that once PTH in the body becomes lesser, the values of serum calcium in the blood of the patient, ionized calcium in the blood of the patient will also be lesser. If you have less PTH and less calcium, the impact on the patient will be either we could have acute manifestations or we could be having is chronic manifestations. So I will be first handling the acute manifestations and then we will talk about the chronic. For acute one, I can say the clinical situation can be that a patient of yours underwent a thyroid surgery. And after undergoing a thyroid surgery, after 72 hours, because in thyroid surgery, the surgeon inadvertently removed the parathyroid gland also. So after 72 hours in this patient, there is a possibility that there would be development of features of tetany. Since PTH values have been falling, the serum calcium of this patient will also begin to fall. Now, because in the patient, the serum calcium is beginning to reduce, what will happen will be tetany, remember, is seen when serum calcium is less than 7. So when the serum calcium of the patient will begin to fall, ionized calcium will also begin to fall. That is when the person will start complaining of perioral and periungual paresthesias. There would be tingling sensation around the lips and tingling sensation around the fingertips of the patient. So perioral and periungual paresthesias could be present in this patient. In this particular patient with perioral and periungual paresthesias, you will apply a BP cuff in the arm of the patient. This BP cuff will be deployed by you to demonstrate the presentation of Trousseau sign, where you deploy the BP cuff in the arm of the patient and inflate it to 20 mm above systolic blood pressure. There will be triggering of carpopedal spasm. This carpopedal spasm is also known as obstetrician's hand because of the peculiar position of the thumb of the patient. That would be adductor spasm. You will then tap on the anterior border of the parotid gland of the patient to elicit Chauvostock sign. Chauvostock sign, there would be clenching of the muscles of one side of the face of the patient. This is tap on the anterior border of the parotid gland. Tapping on the anterior border of the parotid would result in contraction of the muscles of one side of the face. This will result in an appearance as if the patient is in a lot of pain or discomfort and would be called as facial grimace. In these patients, we are worried because the patient will start developing stridor. This patient can die because of laryngospasm. For these patients, the immediate management would be to provide to the patient IV calcium gluconate. So post thyroid surgery, if a patient is having manifestations discussed here, calcium gluconate should be given. But this is not a permanent solution. The drug of choice for surgically induced hypoparathyroidism. SX would mean surgical induced hypoparathyroidism. We will have to give injections of teriparatide to the patient. Teriparatide has been approved for management of patients who are having surgically induced hypoparathyroidism. Not routine cases, but surgically induced hypoparathyroidism, teriparatide is definitely indicated. So we can manage the acute manifestations pretty comfortably if we go in for early identification. But if a patient is having chronic hypocalcemia, then the manifestations are a little difficult to identify from nutritional rickets. So let us see what are the clinical features that are noticed by you in any patient having a chronic hypocalcemia. Here the PTH is reduced in the patient, so the features of the patients would be that of rickets-like illness. The features of the patients will be that of rickets-like illness. I'm using the word rickets-like illness in a patient to highlight that this is definitely not nutritional rickets. One of the early features that will be encountered in these patients would be that of ping pong skull, that is craniotapes. Craniotapes would imply that the skull of the patient will be very soft and can be easily deformable. The second feature will be usually seen after 6 months, that there would be widening of the wrist joint of the patient. Because of the soft bones, because of the distal end of the radius having insufficient calcium deposition, there would be, or because of pressure, widening of the wrist joint of the patient, the distal end of the radius is splayed. In these patients, the leg muscles will also be, the bones of the legs will also be relatively short. These patients will tend to have a disproportionate short stature. What you imply by the word disproportionate short stature is that the legs of the patient, especially the femur and the tibia, would be relatively short. There will also be a wide open anterior fontanelle. In the mouth of the baby of 1.5 years of age, there will be no teeth. Delayed dentition is defined as no teeth in a baby beyond the age of 13 months. So beyond a wide open anterior fontanelle, there would be a delayed dentition developing in a patient. Subsequently, in these patients, you could be having skeletal abnormalities. Now, one of the skeletal abnormalities that could be encountered or seen in these patients could be that the patient could be having is knock knees. Another possibility can be that these patients could be having is development of bow legs, BOW, bow legs. And another possibility can be that the patient can be having on one leg, the patient could be having a knock knee, contralateral side there would be a bow leg. In one side there would be a valgum, and other side there would be a varum in a patient. The third one that I've drawn, this is known as wind swept deformity. This would be genu varum, and this would be genu valgum in a patient. So genu valgum, genu varum, and wind swept deformity. These are the three bony deformities that can be encountered in patients with rickets-like illness. Now, I want you to pay special attention to part number 7 of this discussion, and I want to highlight the fact that 1 to 6 can be seen in nutritional rickets also, but for part number 7, I would like to say that these patients would be having a short fourth and the third metacarpal bone. Now, what is the significance of it? The significance is that if you make a fist like this, you and me can see the knuckles. We can see the knuckles here, like 4 knuckles can be seen. In these patients, the third and the fourth metacarpal bones are shorter. So because the third and the fourth metacarpal bones are shorter, these bones are metacarpal bones are shorter, you would not see a knuckle here, you would rather see a dimple here. So you would get a knuckle, dimple sign here. Looks funny, knuckle, dimple sign. This knuckle, dimple sign is also known as Archibald sign. I'll repeat the data again. One of the clinical feature that is encountered in patients who are having rickets-like illness due to PTH deficiency is known as Archibald sign. In Archibald sign, when you make the fist in the hand of the child, you will be able to feel the initial 2 knuckles. But you will not be able to feel the subsequent 2 knuckles because of the fact that the metacarpal bones are shorter. There is a short third and a fourth. This is third and a fourth metacarpal bone. So the manifestation that we just discussed, that is short and third and fourth metacarpals, this is known as Archibald sign, or is also known as knuckle, dimple sign. This feature will help you in differentiating the particular patient from a patient who's having nutritional rickets. And all these features that I have mentioned here before you of chronic hypocalcemia, that is rickets-like illness in a patient, are technically known as Albright hereditary osteodystrophy. So AHO, that is Albright hereditary osteodystrophy, this is a term that is used to explain the fact that this patient will definitely be having bone changes due to the fact that there is a deficiency of calcium. They might even mimic features of vitamin D, but then you can easily differentiate this from traditional nutritional rickets because we don't have part number 7 discussed. So AHO, Albright hereditary osteodystrophy, is a feature of hypoparathyroidism in a patient. And when I have to work up this patient, obviously because I need to differentiate this person from this patient from that of traditional, I have to differentiate this patient from that of traditional rickets. So let's look at the workup of this guy. When I do the blood work of this patient, I will notice that this is not a standard case of nutritional rickets, because in a standard case of nutritional rickets, you will always notice that the SAP values would be elevated. But in this patient, you will notice that the SAP values would be normal. Calcium would be less, phosphate would be increased in the patient. Calcium and phosphate always go the other way, so that's okay. But SAP values would be normal in this patient. That will alert you to the fact that this is unlikely to be nutritional rickets. Then, when you will check the serum PTH assay of the patient, you will notice that in this patient, the serum PTH values will be down in the dumps. The values will be tremendously low. Initially it might look like a laboratory error, but then SAP is normal in the patient, PTH is less, so you are thinking in terms of damage to the parathyroid gland. Though we don't need to do this next scan, that is a technician maintenance scan, I want to say the fact that if on a technician maintenance scan, that is a system EB scan in a patient, if you have a decreased uptake, it means the fact that the gland is destroyed due to autoimmunity. But if you have a absent uptake, that means it could have been surgically removed also. And in patients who are having Dijot syndrome, there could be a possibility that there is a parathyroid hypoplasia, so there could be decreased uptake. So decreased to absent uptake indicates the fact that the problem starts from the gland of the patient. For management of these patients, obviously supplemental treatment would be given. Calcium supplements are obviously required for the patient. Vitamin D supplementations are required for the patient. But there is no drug of choice for management of hypoparathyroidism in a patient. Teriparatide is not FDA approved for hypoparathyroidism. It is FDA approved for surgically induced hypoparathyroidism, but not for traditional hypoparathyroidism, which could be which is secondary to either, I would say, autoimmunity or secondary to presentation of Dijot syndrome that could be presenting since birth. The topic that I discussed with you here is known as hypoparathyroidism, where I divided the discussion into the acute and the chronic variety. Now in MCQs, what happens is that he will make you compare these findings with that of pseudo hypoparathyroidism. So listen to the data carefully. In pseudo hypoparathyroidism, what happens is that PTH is present in the body, but the problem is not of PTH, it is that of the receptor. In this particular case, what happens is that the receptor is misbehaving. There is a receptor resistance in a patient. Well, why is the receptor misbehaving? That is due to a defective gene by the name of gene in the patient. So in these patients, due to receptor resistance, the PTH values in the body of the patient will begin to rise. Like in type 2 diabetes, because receptor is defective, the hormone levels will increase. Similarly, here there is a receptor resistance in a patient due to gene, and therefore in the patient the PTH values are increasing. In pseudo hypoparathyroidism, please remember the fact that PTH is present but it cannot stimulate the receptor, so features will be identical to that of hypoparathyroidism. Because the clinical features of this disease will be identical to that of hypoparathyroidism, and this condition is present since birth. Hence, in this patient, you could be having clinical features of Albright hereditary osteodystrophy. You see, I taught you Albright hereditary osteodystrophy is rickets-like illness. I'm discussing it here because I want to tell you that in these patients, PTH is available in more than normal amount, but it is not able to stimulate the receptors in the bone. It is not able to do its routine tasks. So that's why the bones are weaker and therefore there is a rickets-like illness. So Albright hereditary osteodystrophy is seen in hypoparathyroidism due to deficiency of PTH. Here it is defect of the receptor. Because of the fact that the same clinical feature is seen, therefore this would be called as pseudo hypoparathyroidism. Let us see the report. You will check the calcium and phosphate and SAP values of the patient, and you will notice the fact that in this case calcium will be less, phosphate will be more, SAP would be normal. In fact, the report will be same as that of hypoparathyroidism, because in hypoparathyroidism it is deficiency of hormone. Here it is present but can't act. You see, the receptor is defective. So because the clinical feature is the same and the laboratory report is the same as that of hypoparathyroidism, you call it pseudo. You see, this report I also mentioned superiorly. Low calcium, more phosphate, normal SAP. This can occur due to hypoparathyroidism, or it can also happen in pseudo hypoparathyroidism because receptor is defective. So I can just put it like this, that in type 1 diabetes we study insulin is less, in type 2 it is more. Similarly here receptor defect, so it is more. In this case there is no definitive treatment available for the patient. There is no teriparatide advantage that is present in this condition. Teriparatide will anyway not work because receptor is defective. So pseudo hypoparathyroidism can be differentiated from hypoparathyroidism on the basis of values of PTH, but then in both conditions calcium would be low. In hypoparathyroidism anyway calcium is low, understandable, but in pseudo, because it's a defect of the receptor, that's why calcium is less. Now in some multiple choice questions, instead of asking you regarding pseudo hypoparathyroidism, he can ask you regarding what is known as pseudo hypoparathyroidism. Now when you read this name pseudo hypoparathyroidism, it looks a little intimidating at the moment, but I want you to remember the fact that when it comes to PPHP, that is pseudo hypoparathyroidism, this is written in short form as PPHP. Let's look at the problem. In this particular medical condition, PTH is present in the body, but the action on the bones is defective. Because the action on the bones is defective, so these patients can also be having skeletal abnormalities, can be having delayed dentition, they could be short stature in a patient, knock knees in a patient, windsor deformity in the patient, and therefore action on the bones is defective. So these patients would be having clinical features identical to that of Albright hereditary osteodystrophy. But the action on the kidney of PTH would be normal. Because the action on the kidney of the hormone would be normal, the phosphate values will be normal in these patients. I repeat the data again. Pseudo hypoparathyroidism is one of the longest medical diagnoses that you will write in your career. It's a long word spanning 35 alphabets. This disease occurs due to genomic imprinting. Genomic imprinting is what you study in pathology with respect to Prader-Willi syndrome and Angelman syndrome. Similarly here, genomic imprinting. Like you know that Prader-Willi comes from the father's side. Similarly, I want you to remember the genomic imprinting PPHP also comes from the father's side. Well, what is the problem? The problem has no parallel in medical science from the endocrinology perspective, that the hormone is acting normally on one tissue and abnormally on the second tissue. The action is abnormal on the bone, so skeletal deformities would still be present. That's why the features are that of clinical features are that of Albright hereditary osteodystrophy. Now, how would you differentiate this condition from the previous ones that we have discussed? You will notice the fact that phosphate is normal. Even in this condition, there will be Albright hereditary osteodystrophy developing in a patient. AHO is encountered in hypoparathyroidism. AHO is found in pseudo-hypoparathyroidism. Now I am saying AHO is found even in pseudo-hypoparathyroidism. So because clinical feature is same, therefore we call it pseudo twice. Because the features are same as that of pseudo and the features are same as that of hypoparathyroidism. In pseudo-hypoparathyroidism, if you check the values of PTH in the blood, the PTH levels are normal. The topics that are to be remembered here are hypoparathyroidism, pseudo-hypoparathyroidism and pseudo-hypoparathyroidism. In hypoparathyroidism in a patient, there will be Albright hereditary osteodystrophy. In PHP and in pseudo-hypoparathyroidism, there will be Albright hereditary osteodystrophy. In all of them, the reason why bony defects are present are basically because PTH is less, PTH can't act, or the action on bone alone is defective. However, you can differentiate between these conditions in a sense that phosphate values will always be increased in hypoparathyroidism and pseudo-hypoparathyroidism, but will be normal in pseudo-hypoparathyroidism. In hypoparathyroidism, PTH is less. In pseudo-hypoparathyroidism, defect of receptor, PTH is elevated. The problem here is in the receptor. And in pseudo-hypoparathyroidism, PTH in the body, the levels are normal. It's only the action which is on the kidneys which is normal, but the action on the bones is defective. This is a summary table that I wanted to remember for these particular three disorders. That is, all three will be having AHO with knuckle dimple sign. How can you differentiate between the two? That is based on the values of phosphate and PTH. The first condition, hypoparathyroidism. This is due to autoimmunity. The second condition, which is by the name of pseudo-hypoparathyroidism, is due to a defective gene. The receptor is defective. And in PPHP, it is a hormone, it is a tissue specific action. Action on the bones is defective, but action on the kidney is normal. The first condition will always have less PTH. Second condition will have defect of receptor, so it is more PTH, and third will have normal PTH. All will be having identical features of Albright hereditary osteodystrophy with knuckle dimple sign, and you can differentiate them on the values of the phosphate. If they ask you regarding what is the cause of secondary hyperparathyroidism in a patient, then the most common cause of secondary hyperparathyroidism is renal failure. Chronic renal failure will cause this increase of PTH because in this condition vitamin D synthesis is lesser. If vitamin D synthesis is lesser, the calcium values in the blood are lesser, and if calcium is less, then it will cause a stimulation of calcium sensitive receptor on the parathyroid gland, and therefore the values of PTH in the blood will begin to rise. Because PTH is increasing but is increasing after so many changes, that is the reason why we are saying the fact that in secondary hyperparathyroidism the cause is renal failure, and due to deficiency of vitamin D there is more PTH. Just to knock some sense into this discussion, so we need to compare manifestations of primary hyperparathyroidism with that of secondary hyperparathyroidism, hypoparathyroidism, and then pseudo hypoparathyroidism. The difference between hypoparathyroidism and pseudo hypoparathyroidism is with respect to the defect in the receptor. Let us just quickly evaluate the values of calcium, phosphate, and SAP for these patients. The comparison will be made 3-point with respect to calcium, phosphate, and SAP. In hyperparathyroidism, the cause is there is a tumor of the parathyroid gland of the patient, due to which there is more PTH, and therefore calcium is up, phosphate is lost in the urine, and SAP is increased. In secondary hyperparathyroidism, the cause is CKD, chronic kidney disease. This will cause less synthesis of vitamin D3, and because vitamin D3 is less in the body, there would be a deficiency of calcium, there would be a higher phosphate inverse relation, and the SAP in the patient would be increased. In hypoparathyroidism in a patient, it is autoimmune destruction of the gland. Due to autoimmune destruction in the gland, the values of PTH in the body will begin to fall. So SAP values will definitely remain normal in the patient, but calcium will be less because PTH is less and phosphate will be increased. Calcium, phosphate go other way around, both opposite, so that's okay. But SAP is normal. I warned you that in the beginning only, that SAP values are not reduced in hypoparathyroidism. They are normal in hypoparathyroidism, and they are reduced in hypophosphatasia. Pseudo hypoparathyroidism is due to a defective gene. The gene is known as GNAS gene. This is the defective gene in the patient. And in patients having pseudo hypoparathyroidism, what you will find is that the report will be same. Because the report is the same, the clinical features are the same. That is the reason why you call it a pseudo hypoparathyroidism in a patient. So this is the comparison of the reports that I have mentioned here before you with respect to these 4 disorders. You see, when you read this topic, first your objective should be to differentiate between primary, secondary hypoparathyroidism and pseudo hypoparathyroidism. If you look at the direction of arrows, you will always notice calcium phosphate will always go opposite. So that is not a cause of worry. SAP values are to be remembered normal for hypoparathyroidism and pseudo hypoparathyroidism. They are reduced in hypophosphatasia. Try practicing this table by yourself. Listen to the discussion once again and then try to work out the table by yourself in the shortest possible time frame. This is not 4 MCQs, this is one single MCQ. He could say all are true about calcium metabolism except, and he can make you talk about increase or decrease of the values. You will also notice that in this table, there is a, by accident I would say, there is a increase in the phosphate. The increase of phosphate is due to 3 reasons: secondary hyperparathyroidism, hypoparathyroidism, and pseudo hypoparathyroidism. So these 3 causes of hyperparathyroidism are also to be remembered by you. The most important cause for hyperphosphatemia to be remembered by you is CKD, chronic kidney disease, or secondary hyperparathyroidism is the leading cause for why you would be having an increase in the value of phosphate in the body of this patient. Once you remember this table, primary, secondary hypo and pseudo hypoparathyroidism, then we can just quickly revise how to differentiate between hypoparathyroidism, pseudo hypoparathyroidism, and pseudo hypoparathyroidism. This was autoimmune destruction of the gland. So PTH will be less. In this condition, the problem is of the receptor. The reason for receptor malfunction in the patient is GNAS gene. So PTH in the body of this patient will be increased because it's a receptor defect. In PPHP, it is genomic imprinting. In this condition, there is a tissue specific action, that the action on the bone is defective, but the action on the kidney is normal in the patient. So we can differentiate between the 3 conditions on the basis of values of PTH. In all the 3 conditions that are discussed here, there will be features of Albright hereditary osteodystrophy. And phosphate values can again be used to differentiate between them, because in hypo and pseudo hypoparathyroidism, phosphate values of the patient will be elevated, whereas phosphate values will be normal in PPHP. Phosphate values are elevated in hypoparathyroidism and pseudo hypoparathyroidism, and how to differentiate between them, you can go in for PTH values, which I am teaching you. Hypoparathyroidism PTH is less, pseudo it is elevated, and phosphate values are normal in PPHP. So this is details for calcium metabolism that you need to remember. If you have any issues, you can definitely contact me at my email, that is marwahmedicine@gmail.com. Marwahmedicine, MARWAH, marwahmedicine@gmail.com. Calcium metabolism, I think, is something which is very important, scoring from the exam perspective. So try to basically work this data up by yourself, write it on a piece of paper and try to practice. That way you get more confidence. Like, logic is fine, but then understanding and being able to write it is totally a different ball game. So a little bit of practice is important for calcium metabolism. Do remember the fact that calcium and phosphate always go in opposite direction. That's the basic rule that I have told you for all MCQs of internal medicine. I'm going to break that rule for a topic which is actually senior pediatrics, but I'll just break this rule. Calcium and phosphate going in opposite direction. Listen to the data. Nutritional rickets. In nutritional rickets, vitamin D in the body is less. That's because there's a dietary deficiency, right? So what will happen is that the calcium in the body will also be lesser. If calcium is lesser, it will cause release of PTH, and PTH will cause phosphate wasting. So because PTH will cause a phosphate wasting in the patient, there would be a urinary loss of phosphate, and because of the urinary loss of phosphate in the patient, there will be a hypophosphatemia occurring in the patient. If you look at the arrows, you will notice the fact that in nutritional rickets, calcium is less, okay, and then there is also less phosphate. When I say this, a lot of guys say why the same thing is not valid in patients who are having chronic renal failure. In chronic renal failure also vitamin D synthesis was lesser, so same thing should be applicable. You see, there the point is that because kidney is inward, the phosphate loss will not occur. Because it's CKD, there will be retention of phosphate in the body. This guy is having normal kidney function. That is the reason, because kidney is normal in this case, that you will have a hypophosphatemia. So if you ever notice in a question, calcium phosphate going in same direction, it is unlikely to be PTH. It is rather nutritional rickets which will have these values, and obviously this should help you in questions. Nutritional rickets, where you will treat the patient by giving 6 lakh international units of vitamin D that can be given to the patient either in the form of sachets. You can either give it intramuscular single dose or sachets to the patient. Rickets is covered in pediatrics. That's beyond the scope of this discussion, nutritional part. But I did want to bring to your attention the fact that in nutritional rickets, why phosphate is less is because urinary loss is happening, and in CKD, well, kidneys are involved, so you would not have a loss of phosphate from the circulation or loss of phosphate from the body.